the shock team in cardiogenic shock with Amir Kaki. So wonderful to have you here. He's the director of mechanical circulatory support and complex coronary intervention, a fantastic operator. He's been trained by some of the best people, but also he himself is training the next generation. He's the associate director of interventional cardiology at St. John's Hospital and Medical Center in Detroit, Michigan. We're so proud to have Amir here. Welcome, Amir. Shock team in cardiogenic shock.
So my name's Amir. Thank you for having me. I actually did my training here in New York City at Lenox Hill in 2008. I finished and then had the opportunity to go to Detroit in 2012. So I'm going to speak about the shock team and cardiogenic shock. And I think just as an overview, I think everybody knows shock mortality has been very poor for the past 3 decades, been stagnant at 50%. And we're fortunate to have Dr. O'Neill here, who has really pioneered and led the charge to really change that significantly. And I think in this presentation, which is going to be case-based, I think that there is some hope that we could achieve Dr. O'Neill's vision of having 80% survival in cardiogenic shock, which when that happens, I think will contribute to a very amazing legacy that he's done for us in cardiology. These are my disclosures, and I'm going to make this case-based because I think that's the best way to learn. The acute objectives of AMI shock historically was, we learned from Judith Hochman that if we open up the artery, we had a mortality benefit. But I think we're at a stage now that we have to look beyond the coronary artery, and we have to look at circulatory support and ventricular support, and we'll talk about that. And this is a concept from Naveen and Dr. O'Neill. So here's my case. A 60-year-old female. This is a case that I did maybe about 4 weeks ago. 60-year-old female presents at a satellite hospital in Southeast Michigan. Initially comes in with chest pain, and she has nonspecific ST changes. In the ER, she actually has a VT arrest that is witnessed. She has CPR for 30 minutes, and subsequent EKG shows anterior ST elevation MI, so she goes to the lab appropriately. But after, keep in mind, she had 30 minutes of CPR, and she's a 60-year-old woman. Why is that important? Here's her past medical history: hypertension, diabetes. She's morbidly obese. She has sleep apnea and dyslipidemia. Here's her labs upon arrival. Nothing remarkable. Now, here's her diagnostic angiogram. You can see she has a thrombotic occlusion of the proximal LAD, and the LAD gets opened up. He has TIMI3 flow. So here's the index procedure. What happened? LV-EDP was measured to be 28. Notably, a right heart cath was not done. TIMI3 flow was established rather efficiently. The patient left the cath lab on Levofed, a single pressor. This is not a rhetorical question. It is something for everyone to ponder. Did the operator do enough for this patient? That is kind of the standard of care. We talk about door to balloon. That's how we're judged. Was that enough? What did the operator do as it relates to circulatory support? Is it appropriate to leave a patient, leave the cath lab on a single pressor? And what about the LV? So what are we going to do with this? So as you would often see, and potentially you could predict, had you done the hemodynamic assessment, this is what happened to this patient. The patient got taken back to the cath lab 4 hours later because the patient had continued decompensation, required more vasopressor support. Now you'll notice that the operator did do a right heart cath. So unfortunately, Impella is not a panacea for shock. It's a very good, robust device. But for us to get this survival that we want, it's not going to be enough in a lot of patients. So despite having a robust Impella CPN, the patient vasopressor support went up, currently on 3 pressors. And a really important biomarker, which Dr. O'Neill will talk about in the cardiogenic shock initiative, what we learned is the lactate. This patient's lactate was going the wrong direction. So you have rising vasopressor support and a rising lactate, at which point the operator did the right thing and sent the patient to a shock center for escalation of care. Upon arrival to our institution, here's the patient. The patient comes in on Impella CP, moderate doses of 3 pressors. We did a right heart cath. The right atrial pressure is 20. The PA pressure 49/28. Mixed venous O2 is a very important number. I think way underutilized in the cath lab, but critically important in the shock population. We should be doing it on all these patients. It has tremendous value. The cardiac index was 1.6. The cardiac power output, also we learned from Dr. Hochman and from Dr. O'Neill's work, this is the most important critical predictor that we have for survival. 0.4 bodes for a very poor prognosis. At this point, the patient came in with univentricular, with single organ failure now, 2 organ failure. The patient has respiratory failure requiring high settings, PEEP of 8, and vent settings of 100% at 502. So what happened to this patient? So sorry, let me tell you. So that's what happened to the patient. And here, just one slide about the right heart cath in shock. In my opinion, 100% of patients who have cardiogenic shock should have a right heart cath. The reality is, if you ask everybody, they say, yeah, we do it. It's like IVUS in imaging. Everybody, if you ask them, everybody's 100% IVUS user or imager. But when you look at the data, it's very few people. Now, this is a recently published paper. It turns out that most 20% of people who have cardiogenic shock in this country and go to the cath lab do never get a right heart cath. And then the remaining 40%, for a total of 60%, get incomplete right heart cath hemodynamics, and only 40% right now, as of 2020, actually get a full hemodynamic profile. Why is that important? If you can see, there's an association with a significant improvement in mortality in patients who get right heart guidance of their treatment of cardiogenic shock. Keep in mind, to the naysayers who say right heart cath do not help our patients, in a heterogeneous population that was true, but in a homogeneous population like cardiogenic shock, that is not the case. So the SWAN is not therapy, but it does dictate therapy and provides you actionable data that you could do to potentially help your patient. And it did in our case, because in our case, this is the decision making. The patient had a rising lactate, multiple pressors on a very robust pump, despite that decreasing cardiac index, decreasing mean arterial pressure with a low cardiac power output, low mixed venous saturation. And then we calculate the SAVE score, which is really important. This is the survival after VA-ECMO cannulation. This patient's SAVE score was 42%. And depending on your ECMO program and your survival statistics, will depend on your appetite to do a case like this. In my opinion, 42% in a 60-year-old patient who was highly functional, otherwise healthy, was worth the try. So here's our escalation options. You could do an Impella 5.5. The limitation of that is you need a surgeon, and it's time sensitive, and oftentimes the surgeon may not come in the night, you may not have resources, anesthesia, et cetera. What we can do in the cath lab is we can do a VA-ECMO as an escalation strategy, and you could do that totally percutaneously, and Acapella is percutaneous. So we decided to go with Acapella on our patient. We put a 29 French drain in the patient on the venous side. On the arterial side, on the left femoral artery, the patient had the Impella, which was peeled away. And on the right, we did an antegrade stick a priori before we put in a 19 French arterial cannula. The Impella stays in, and that's really important because you need the Impella to vent a patient who's in cardiogenic shock who has ECMO. So if you go back here, vascular access is critically important. Here's the vascular access. You can see on the right femoral artery, we have a 19 French arterial cannula. Downward, we have a 5 French sheath. That's a perfusion sheath. It's being donated. Blood is being donated from the cannula. And then we have our right heart cath. On the left side, the Impella came in from the other hospital with the peel-away sheath. And then we have a 29 French drain on the other side. So vascular access is critical to escalation. Now look what happened to the patient's biomarkers on Acapella. The patient came with a lactate of 14, and we're going to understand the prognostic implications of failing to clear lactate when Dr. O'Neill speaks. But look what happened to this patient. In 4 days, you could see the curve. We were able to clear this patient's lactate on Acapella. And what that resulted in the patient being decannulated, and the decannulation was done in the cath lab. So you could see here what was left on the right femoral artery, totally percutaneously. I like to do completion angiograms on 100% of large bore access sheets, and you could see where the Impella once was on the left, and the 29 French cannula, both growing access sites look good. This patient did not suffer vascular access complication nor require transfusion. So look at the vascular access complications you should expect. ECMO has the highest vascular access risk, about 16%. Impella actually gets a bad rap, but if you look at the real data, it's about 6%. And obviously balloon pump, because it's lower profiles at 2.9%, but you're trading off for not a robust situation. So is it the teams? Is it a shock team, or is it a technology? How are we going to improve survival in shock patients? It's a combination of both. You have to have you have to have a skilled team that knows how to do escalation strategy, who is very good at vascular access. Critically important to understand hemodynamics, and you have to have the technology to do it. Unfortunately, we don't have a good percutaneous option for escalation, except ECMO. At this time, we can't escalate to a 5.5 right now, but hopefully in the near future we will be. I think this is the future of cardiogenic shock. You're going to have centers where they have shock teams who are very skilled and competent. They have all the disciplines that you need, and we're going to be able to put Impella eventually, maybe small bore Impella such as an ECP or a CP, and escalate these patients to centers where they have 5.5 and potentially ECMO. These are the different specialty specialties, I think, that are really important. You need critical care doctors. A lot of these patients are on the ventilator, particularly when they get on ECMO, advanced heart failure doctors to care for them, and then our surgeons. Obviously, cardiologists will be the focal point of taking care of these patients. So what, let's see, can my slide go forward? It's kind of stuck there. Okay, here it is. So the goals of your program should be 100% utilization of pulmonary artery catheters. You should protocolize the care. Early implementation of advanced MCS, particularly impellant ECMO, is critical. Large bore vascular access skills, how to get the access, how to provide shunt so you don't get ischemic legs, and having a team. And everybody on the team has to be really good for this to be successful. So here's the take home. Shock teams are more likely to obtain invasive hemodynamics. They're more likely to use advanced MCS if you have them formalized. They have a lower adjusted mortality risk, and they're more likely to use protocols. And actually, this is our patient. This lady actually walked out of the hospital. If you keep it 30 minutes of downtime and had ECPella for 4 days, the prognosis for these patients is historically poor, but now we have the skills, the knowledge, and the tools to have survivors like this. So with that, that's my family. As usual, thank you guys for having me. It's a pleasure.